thing. But let me get back to, we sort of took a detour, and let me get back. We're still coming back talking about, I want to ask you a little bit more questions. So how do you decide if a patient is go for monotherapy or the dual therapy, right? And you mentioned one aspect about if you only lung versus liver, brain, bone, and in those second cases, you will be more aggressive. You put them on a dual therapy. What about the patient itself, like the age, the comorbidity? Does that take into consideration?
It can. The patients, some patients, if you give them a choice, some patients will opt for the lesser treatment in the hopes of having less toxicity. But it is a bigger problem in patients who are very medically unfit for side effects. And it doesn't sound like it would be a big problem, but it's pretty common that patients have underlying autoimmune conditions that make giving them checkpoint inhibitors a little bit of a problem. Patients, with history of inflammatory bowel disease, for example, inflammatory arthritis, those things get worse on checkpoint inhibitors, and so that makes it harder to treat those patients. But as a rule, all things being equal, the way I do it is my default is to give a PD-1 only, unless there's something that's moving me to give two drugs. It's usually the extent of disease.
Gotcha.
Brain for sure. We know for sure brain metastases respond better to dual therapy compared to Nivo